Hello everyone, this is Shad Reis and this is SIF 2022. Is with me Dr. Kush Agrawal. He is interventional cardiologist at Atrial Health, but he has been recently phenomenally been involved in a lot of PVD work. Dr. Agrawal, thanks for being with us.
Thank you, Shadi. It's a pleasure to speak with you. Thanks for a couple of minutes of your time.
Sure.
I wanted to just say, I think the conference is going really well. We've been able to highlight some conversations on VTE, in particular PE response, and how it's really growing like hotcakes. Absolutely. And it's really helping to meet a need that is, as of yet, fairly unmet in our communities.
Absolutely, but just want to highlight one thing before we dive deep into the technology and the great work you do. Why now interventional cardiology start to get attention to the PVD work in the venous space?
Yeah, and I think that it's a very fair question to ask about why is our Venn diagram sort of overlapping with our colleagues in IR and vascular surgery, which I see it more as a collaborative effort. Really our collaboration with industry has helped quite a bit in allowing us to use techniques that piggyback on our own skills that we train with microcatheters, small wires, localized access, and thanks to industry, thanks to device improvements, thanks to improved safety margins with the aggressive devices that we use for thrombectomy and angioplasty, I think we've really been able to have great outcomes, and so it's become much more accessible to a wide variety of angiologists of different flavors.
Awesome. So tell us a little bit about your practice, especially in the venous space.
Yeah.
What are the things that you treat?
Thank you. I practice here in Scottsdale, and there's especially I would say with COVID, there's been a surge of VTE, DVT cases. I treat a high volume of DVT, and quite frankly, there's a very high skew and bias towards seeing patients who present with recurrent DVT who have underlying May-Thurner syndrome and iliac vein compression syndromes, acute on chronic. So I treat a lot of chronic DVT as well, and iliac vein compression syndromes. With iliac vein angioplasty and stenting. We treat a lot of IVC reconstructions in our practice, and so it's been really great to learn to explore that more and to use the dedicated stent technology for that, and to really try to give an additional layer of offering to our patients. It's really been a great delight to try to be a better doctor and offer more.
One of the questions comes up is for acute DVT or chronic DVT, when they should come and seek attention from an expert like you to get treated. If, let's say, they're already on anticoagulation, but still we think they should see you.
That's a great question. Thank you. I get a lot of calls from acute care colleagues, such as ER and oncology and critical care, and that's a fairly easy to understand referral. For chronic DVT, certainly it's very reasonable when you talk about lower extremity venous ulceration. A lot of times it's related to chronic DVT and IVC occlusions or iliac vein occlusions that can be recanalized. And so patients with significant unremitting edema, venous ulcerations, that's a really great place to start. Recurrent DVTs, recurrent VTE, it's not necessarily an anticoagulant failure. And there's often a sinister mechanical component to the conversation.
Yeah.
So
and these patients usually you prefer to be referred to you early on in the phase of the disease, or any phase is fine?
Yeah, earlier is always better, as you may agree, Shadi. The reason is that it is much more feasible to recanalize a recent total occlusion than a chronic.
Yes.
Yeah.
And
safer for the patient.
And for chronic, what should be in the toolkit for chronic DVT? Because usually it's challenging, especially with popliteal access and chronic DVT.
Yeah, access is more than half the battle. In particular, you're often dealing with IVC filters that have been in for some time. So you've got to have a real comfort level with filter removals, understanding of filter tilt and risk. You've got to have laser in your lab. You've got to have balloon trapping. You've got to have the ability to early stent technology within the IVC, wall stents, Medtronic stents, reconstructing an iliac vein. So that skill set has to be there, and you have to be very facile and comfortable with that. But we have great support from Inari, from Penumbra, Medtronic, as far as devices in this space. But access is more than half the battle. You're right. You have to be comfortable with ultrasound-guided access of the IJ, the common femoral vein, the popliteal vein.
What is the role of imaging before you bring somebody? Is there any role referral for certain imaging before you bring somebody to the lab?
Thank you for that question. So oftentimes when I'm referred a chronic DVT, a recurrent VTE, or C5 or 6 venous ulceration patient, one of the first things we'll do is obtain a CT venogram as well as an IVC of an IVC ultrasound, abdominal ultrasound, in addition to venous reflex testing of the lower extremities. So working with your technicians in the office and in your local radiology imaging lab is going to be very important for high quality imaging, so that you have a better direction of procedural planning.
Laid out the ground for you to plan your procedure.
Absolutely. Yeah. So that's half the key to success.
Absolutely. So after, let's say, focus a bit on May Turner, you treat him with stenting. There's no DVT. Do you usually recommend antiplatelet or anticoagulation for these patients? Yeah,
and that's a little bit of a gray zone, but there is data to help guide short and long-term outcomes in a retrospective manner. And so what we do know is that acutely, in order to guarantee efficacy, Lovenox is relied upon quite a bit. Especially for the first 6 to 12 weeks post venous stenting. In addition, we'll often add usually a single antiplatelet. It is uncommon to use a dual antiplatelet regimen on top of systemic anticoagulation. And then we discuss broad warfarin use versus maybe more narrowed direct thrombin inhibitor or NOAC or DOAC factor 10 inhibitors, which is a more narrow spectrum. So that's a more individualized conversation. And I'm always working with my colleagues in hematology, so it's really a two-way conversation. So.
For final question about the training that you have, did you have a dedicated training for this kind of space or something you learn on the job?
Yeah, it's probably awkward to have a conversation with a cardiologist about deep vein disease, and that is not lost on me. I'm first of all grateful, and I do think that we do a lot for our patients, and I always ask for help. I trained as part of the Viva Fellows training program in 2015, 2016 with Dr. Jim Joy in California and Dr. Chris Metzger in Tennessee, and I worked hand in hand with interventional radiology and vascular surgery specialists to learn a lot of chronic and acute venous care. Now the landscape of technology has shifted quite a bit in acute VTE care since 2015, and so really it's been quite a bit of in-practice training with devices and with my colleagues locally, and so really it comes back to having a team of people who trust you and whom you trust to work together. So any IVC filter that we retrieve, I don't do it alone. I really work with my colleagues to do that, and it's better for the patient. So we are a team around a patient, and I believe that's really the way it should be, especially with such complex disease.
Absolutely, any complex coronary, as you said, structural and venous now.
Yes,
you have to have a team approach,
and it's not that straightforward. So
absolutely, it's a new space. So for the fellows listening, this is something you should think of if they are looking into a venous space. Maybe you consider an extra training before you go to a job, rather than learning it on the job itself.
Yes, venous disease is very prevalent and sadly undertreated, and so as physicians we owe more to our patients. So for those who are interested in vascular skills, please do extra time training. It's really going to help an extra layer of care for your patients.
Absolutely. So. Well, Dr. Agrawal, thanks so much for your time.
Really
appreciate all the input on the severe peripheral venous disease. Please watch this video and others on SIF YouTube channel. This is Shadil Reis from Detroit Medical Center. Dr. Agrawal, thank you again.
Thank you, sir. Appreciate it.